Hi, I'm Matt Collins, and today I'm going to be demonstrating the failed intubation drill.
Some strategies to help reduce the risk of failed airway include assessment of the airway, effective pre-oxygenation, reducing the number of attempts at intubation, and acting before it's too late. And prepare the patient as best as possible.
Remove my mask. I've got no jaw tone. Grab my size 4 Mac blade, go into the right side of the mouth, sweep the tongue to the left, into the vernacular groove, and I notice I've got grade 2 view. My assistant would pass me my ETT tube, and I'll go and try to place it. And for whatever reason, I can't pass the tube. I can't get it in. And at this point, I need to realise I cannot intubate that patient.
After not being able to intubate, I resort back to a Goodell's airway and bag valve mask ventilation. Here is a guideline for the failed intubation drill. Once second intubation attempt has been undertaken, this is the first step of the failed intubation drill. After your first intubation attempt is unsuccessful, you got to ask yourself, what was the issue? Was there an issue with the airway grade? Were you unable to put the position of the patient in the best position? Use a different size tube, use different techniques to get a better view and better access, use external laryngeal manipulation, retract the lip so you have a bigger mouth opening, jaw protrusion, some help from some assistants, go down to a size 3 blade, get your partner to have the intubation attempt. Do everything you can to make the intubation more successful. The critical question here for each procedure is whether you can oxygenate the patient. Ideally, you want to keep them at greater than 90% SATs, and if you're unable to, you need to move on, and I'll explain this why SATs of less than 90% are critical to the patient. Here is everyone's favourite, the oxyhemoglobin dissociation curve. This displays why it's so important to keep the patient's SATs above 90%. As you can see, when the SpO2 reading hits 90%, there is a sharp dramatic decrease in the PO2 for the patient. This can lead to significant tissue hypoxia and result in cardiac arrest.
Okay, so for my first attempt at intubation, I was unable to pass the tube, and it was difficult. So now I'm going to change some things. I've already got the patient in the optimum position, having them ramped up. But this time with my assistant, I'm going to get them to apply some external laryngeal manipulation. So I'm going to get them just to position their fingers here, and whilst I intubate them, I'm going to place my fingers on their fingers and manipulate it into a position so that I'm able to pass the tube. I can also grab another assistant to do some jaw thrust for me here and just lift the actual mandible up for me, like so. So I'm going to have another attempt, advancing the blade into the right side of the mouth, sweeping the tongue to the left into the vernacular groove, and I've got my assistant with some external laryngeal manipulation, and I'll get my assistant.
For my second attempt at intubation, I utilise the bougie. I can place the bougie, and if I can place the bougie through the cords, I can blind place the ET tube over the top and check for objective measures such as end tidal waveform. Or if I'm unable to pass the bougie at all, I resort back to BVM ventilation.
Okay, so I was unable to intubate my patient on my second attempt. Now I need to resort to the first step in the failed intubation drill, which is Goodell's airway. Measure it up, corner of the mouth to corner of the earlobe. Yep. Place that in, and with BVM. Now what I'm looking for is rise and fall of the chest. I want to see some increase in the SpO2, and I'm also looking at end tidal readings also. And at this stage, I notice that I'm unable to get rise and fall of the chest. The SpO2 is continuously falling, and I'm can't oxygenate, can't ventilate this patient. So I've made the decision that I'm unable to oxygenate and ventilate my patient with a Goodell's airway and a BVM. So I need to move on to the next step. I need to remove the Goodell's and get my eye gel, size 4, so appropriate size for this patient. Need to lube up the posterior aspect of the eye gel and just slide it over the back of the oropharynx, push it in, and it should rebound a little bit like so. Attach my BVM, give some ventilations, and what I'm looking for is rise and fall of the chest again, looking at my SpO2s and my end titers.
After attempting to ventilate with the LMA in situ and not being able to maintain SpO2 levels of greater than 90% and not having good ventilation or oxygenation, poor chest rise and fall, I have to move on to the next step of the failed intubation drill. In the context of imminently falling or persistently low oxygen, a can't intubate, can't oxygenate event is declared following unsuccessful endotracheal intubation, unsuccessful face mask ventilation with OP or NPA, and unsuccessful supraglottic devices. If it is not possible to maintain oxygen saturations above 90% with 100% oxygen and face mask ventilation, this is a can't intubate, can't oxygen situation, and cricothyroidotomy needs to be adopted and implemented. At this stage, when you're declaring a can't intubate, can't oxygenate situation, it's imperative that you declare this is a can't intubate, can't oxygenate situation so everyone is aware of the situation.
Okay, so I'm unable to ventilate, I'm unable to oxygenate, so I'm in a can't intubate, can't oxygenate scenario here. So the biggest thing here is the decision to cric this patient and not deliberate on this any longer. So we're at that decision now. Ideally, in this situation, I would have an assistant here attempting to bang valve mask the patient at the same time that I'm preparing to do a cricothyroidotomy. So my remove that. Got my little airway here. So I've pre-marked my cricothyroid membrane prior to intubation attempts. I've got my quick track here. I pinch the skin, and at 90 degrees, I advance the quick track to the red stopper here. So I've stopped at the red stopper here. I aspirate my cannula, and if I'm able to aspirate, I know I'm in the trachea. From here, I go 60 degrees, and I remove the red stopper, and I push on the cannula until I hear a click, and I know that the green mechanism here is clicked. From here, I'm able to advance till it's flush with skin, removing the sharp. Pull up my cuff. And attach my BVM. Once my BVM is attached, I want to be ventilating at 6 to 7 mils per kilo and approximately 12 breaths per minute depending on the patient's condition and clinical presentation. From here, I'll grab
and secure the quick track to the patient's neck with the cloth. Here is a rundown of the failed intubation drill and how long each procedure should take and how much time should be spent on each procedure.